So I'm very happy to be here in sunny Saskatoon, much sunnier than back home in Vancouver. A little cooler, but that's okay. So as Greg said, I'm primarily an addiction doctor, and one of the places I currently work is a Hartwood Centre for Women. So that is a 30-bed intensive treatment residential centre located in Vancouver, and we have up to 30 women at a time who come and stay with us for 3 months. So they all have severe addiction issues, but generally also some mental health concerns, often physical concerns, often HIV, Hep C and other complications of their addiction, and very predominantly, I would say 99% of the women that we see have significant trauma histories. So it's been a great opportunity working there for me to solidify my practice in trauma-informed care. But my professional journey really started back in the 90s, working in a sexual assault service in Australia, and thereafter with moving to Canada in the Downtown East Side, where I spent a good 5 years doing outreach, providing full primary care, HIV care, linked with addiction care in the Downtown East Side. And that's where I really honed my skills. So what I would like to share with you today from all of that experience. We'll start this morning by talking about defining trauma and exploring its potential effects on the individuals it affects. We will then review some Canadian and US literature. And this afternoon, we can look at trauma in the workplace and how caring for trauma survivors affects us as practitioners. We'll also explore some issues regarding developing trauma-informed services, making your work environment more trauma-informed. Flourish. Taken from me was my childhood, my youth. Finally, I am able to tell the truth. My soul aches with anxiety and despair. I was so lost, I thought nobody cared. The hole inside of me is like a chasm. Whenever I think of it, my heart does spasm. What he did took over my being. That's part of a poem written by one of the women at our centre in the first year that we were open. So what's the big deal about trauma? Trauma and histories of violence are very prevalent in the lives of our patients and clients. I'm sure all of you have discovered this for yourselves. Why is it important? Well, many people living in Canada with HIV are not engaged in regular medical care, and many may not even know that they've been infected with the virus. Perhaps as many as 1 in 4, but we don't really know. Despite the widespread availability of antiretroviral therapy, many are not being treated, and this perpetuates the spread of HIV in part. There are many reasons for this lack of engagement in care, including financial, logistical, sometimes discrimination within the healthcare settings. But much of these issues can be related back to trauma, both individual trauma experiences and at a community level. We know from other settings, particularly mental health and addiction settings, that providing care in a trauma-informed way can improve health outcomes and can be cost-effective to boot. So trauma is very pervasive. There are very strong links between trauma, violence, substance use disorders, mental health and physical health, of course including HIV. However, trauma is shrouded in secrecy and denial. The effects of this pervasiveness are extensive and include mental health effects, substance use, physical health. And this contributes to barriers to accessing treatment for our clients. It stops them from being retained in treatment, and it impairs their ability for long-term recovery. In short, patients who need our care most have the hardest time accessing it. So let's take, how do we know this? I'll quickly go through a few Canadian reports on HIV and trauma. Firstly, the Canadian Aboriginal AIDS Network collates data on HIV incidence and trends, and some of those numbers for Aboriginal women include statistics like Aboriginal women are contracting HIV at a younger age than their non-Aboriginal counterparts, but however they are being diagnosed later on in the disease, sometimes already when it's progressed to AIDS. And they're more and more contracting HIV through injection drug use. The CEDAR project is an ongoing prospective cohort of young Aboriginal people who use drugs. And it looks at their relationship between historical trauma for these young people, sexual abuse, and their HIV risk. So this cohort's being followed in Vancouver and Prince George and is composed of young people from the ages of 14 up to 30. Of these people, 48% report history of sexual abuse, with on average the age of abuse starting at 6 years. Now 48% is way higher than in the general population, obviously. Amongst these young people, there's a significant increase in incidences of many things: self-harm, suicide attempts, emergency department presentations, overdoses, addictions in general, sex work, and multiple sexual partners. And of course, many of these things are risk factors for contracting HIV. The following two studies on the slide there are both generated from the BC Centre for Excellence in HIV and AIDS, located in Vancouver. To summarise, the first study looked at Aboriginal, street youth and female sex workers and found in both groups they had an increased incidence of HIV infection. Female sex workers too had an increased prevalence of HIV, and a history of sexual assault is strongly associated with contracting HIV. In the second study, childhood trauma among HIV positive injection drug users reveals that between 42 and 52% prevalence of sexual abuse in childhood, neglect, emotional and physical abuse. Again, much higher than the general population. Our search for safe spaces. This is a wonderful study if you want to read more about how sexual violence affects Aboriginal women living with HIV and AIDS. This was performed again by the Canadian Aboriginal AIDS Network in 2009 and was funded by CIHR, which is the Canadian Health Research Network. Focus groups were held in Vancouver, here in Saskatchewan and Regina, and in Montreal, so a much more kind of pan-Canadian focus. They did an extensive literature review which really highlights the damaging effects of colonisation and gender inequality, the unique and damaging effects of the residential school system, which we'll probably hear a little bit more about this afternoon, and how the cumulative impact of both of these things has contributed to the HIV epidemic, probably via many ways, but decreased access to health, decreased access to education, the reserve system and gender-based violence. So what did this study show? Well, it found that the women living with HIV/AIDS had a greater exposure to violence during their childhood, not unexpectedly. It also highlighted that contracting HIV was often a violence-related incident, either directly or indirectly. So directly, I mean through a sexual assault or directly from an HIV positive intimate partner, and indirectly through sex work, addiction world, what have you. It also highlighted that HIV-related exposure to violence was ongoing. So once a woman had a diagnosis of HIV, she was often subject to verbal and emotional abuse from partners and family or other members of the community, and may have even been shunned by family members. So very big stigma to this day still associated with HIV. Experience with health and welfare services in itself was increasingly traumatic for some of these women once they had a diagnosis of HIV. So again, related to racism, sexism, and the stigma of HIV. But what was the final message of these women from this study? Overwhelmingly, they said, address the violence first and the HIV second. A little bit like your approach, Greg. Quickly, we'll go through the evidence from the US, because they have a lot more kind of robust evidence in terms of trauma and HIV. So there's a high prevalence of trauma in people living with HIV compared to the general population. And that trauma again is ongoing in adulthood and post-HIV diagnosis for similar reasons as to already spoken about. CHASE is a study standing for Coping with HIV and AIDS in the southeast of the US. And they found an increase in all-cause death rate of 2 times if people had experienced trauma during their life, significant trauma in their lifetimes, compared to people that didn't have a trauma history. So there we can see that the trauma is affecting how their general health and the progression of the HIV. A couple of other studies there just very quickly. Depressive symptoms much more prevalent in women with AIDS, and it's also been associated with progression of the HIV and earlier transition to AIDS itself. 30%, looking at meta-analyses, which means looking at a whole bunch of studies all together around HIV and post-traumatic stress disorder, a very high percentage, 30% I've written down there overall, but many studies show higher rates of post-traumatic stress disorder in the HIV population. And this goes largely unaddressed and untreated, unfortunately. So what is trauma-informed care? It's basically an organisational structure and treatment framework. So it's not a special treatment program that you go to, okay? It's a way of being in relation to our clients rather than a specific program. It involves understanding, recognising and responding to the effects of all forms of trauma. It gives priority to safety, choice and control. So let's just look a little bit at the distinction between trauma-informed services, which is what we all wish to provide, and trauma-specific services. So trauma-specific services treat trauma through specific therapeutic interventions, and for that you need practitioners, counsellors mainly, with specialist skills. So examples of this might be specialised CBT, cognitive behavioural therapy, or DBT, dialectic behavioural therapy. Some of you may be familiar with processes like EMDR, which is eye movement desensitization and reprogramming. And then we can also have services in group format. So Seeking Safety, if anybody knows of Seeking Safety program by Lisa Najovitz, we use it a lot at the Hartwood Centre. It's the core of our programming, and it's basically an addiction treatment group program with a real focus on trauma and its effects and how it is involved in where a person is with their addiction. So they're the trauma-specific services. The trauma-informed services, what we all want to achieve, seeks to discuss the connections between trauma, mental health symptoms and physical health. We want to be able to identify trauma symptoms and help our clients recognise trauma symptoms and the adaptations that they've developed in response to those trauma symptoms. We want to offer supports and strategies to help deal with this and to increase their safety and support connection to other services. So really, trauma-informed care seeks to understand the connection between how a woman or man is presenting today and their past history. So let's step back. What is trauma? Trauma is an experience or experiences that overwhelm an individual's capacity to cope. Okay, so it's about having an external event and feeling like you cannot cope with it. Both internal and external resources are inadequate to cope with the external threat. And they tend to be life events that are out of one's control, and they have potentially devastating emotional, physical, and behavioural consequences. You'll see I've got some artwork throughout this presentation. This is all done by the women at Hartwood Centre generally during their art therapy sessions. Often pictures speak louder than words. So what predicts the ability of an individual to cope with a traumatic experience? So there are many factors involved. The context of the trauma. Is it a single one-off event, or is it repeated ongoing trauma? The age that the person experiences a trauma. So what is traumatic for a 2 or 3-year-old toddler may not be traumatic for a teenager. And what's traumatic for a teenager may not be traumatic for a 40-year-old. Whether the traumatic event is natural or from human hands. Often the traumatic experience will have larger fallout if it's an intentional event perpetrated by a person, particularly if it's someone that is close to you, or particularly if it's somebody that you should be able to trust. Whether the traumatic experience is accidental versus purposeful. So things like earthquakes and tsunamis, car crashes sometimes. Then our ability to cope with this trauma is also determined by what our environmental supports are at the time. Do we have happy, healthy relationships, people around us to support us, supportive friends, family, supportive community, or are we lacking in those things? And finally, innate resilience, and that's something that's not been explored very much, but that researchers are very interested in currently. You know, is there an underlying personality type, or do people have innate resilience that help protect them against the traumas that they may face in their lifetime? So in general, trauma is very unpredictable at a personal level. You need the right constellation of events, plus circumstances, plus a psychological state. So let's quickly look at the types of trauma. As mentioned, we can have a single incident trauma, which is an unexpected, overwhelming event. We may have complex and repetitive trauma, and some examples of this are ongoing abuse, for instance in domestic violence relationships, or living through a war. Developmental trauma is the exposure to early, ongoing, repetitive trauma for infants, childhood and youth. It often involves neglect, abandonment, can include physical, social, sexual, emotional abuse, and witnessing violence. It often occurs within the child's caregiving system, and it interferes with healthy attachment and development, which we'll talk in a moment more. Intergenerational trauma is the psychological or emotional effects experienced by people who live with trauma survivors. So a very good example of that would be the residential school system and survivors from that process. Coping and adaptation patterns develop in response to the trauma for the people that have experienced a residential school, and then get passed on through their parenting to their children and then to their children's children. Historical trauma is a bit bigger picture than intergenerational trauma is one subset of historical trauma. So historical trauma is the cumulative emotional and psychological wounding over the lifespan and across the generations, emanating from massive group trauma. It's inflicted by a subjugating and dominant population, and colonialism in Canada is an example of that. Genocide would be another example, slavery, and ongoing wars. This is all pretty heavy stuff, unfortunately. So, if you're exposed to severe trauma, what are the likely effects? Listed there are psychological, developmental, physical, interpersonal, spiritual, and behavioural. The effects of trauma are very far-reaching, especially when abuse or neglect is ongoing, when it begins in childhood, and when it's perpetrated by somebody close to you. I'm not going to talk much more detail about the physical effects of trauma, but it includes things like chronic headaches, irritable bowel syndrome, raised blood pressure, chronic pain syndromes. What we'll do now is quickly run through each of those bullet points that we just identified. Psychological trauma occurs initially at the time of the event. And I'm sure all of you will be familiar with these concepts of acute shock, perhaps, terror, anxiety, shame and guilt. Some people cope in the first instances with trauma with blocking it out, a very effective way with dealing with something that's overwhelming. This we call dissociation. So there is an emotional numbness and a disconnection from what's going on. You see it in babies sometimes, if everyone's recognised that. If a small baby gets hurt, sometimes they just fall asleep. I noticed that with my 10-month-old when he fell out of his high chair one time and fell down and cried and hurt his hip, and I picked him up and he just immediately went to sleep in my arms. That was the shock of falling and probably pain, and he just slept happily for ages. I thought, nothing much going on. Then when he woke up again, it was obvious that some damage had been done. Acute trauma affects our memory in the form of flashbacks and unwanted intrusive thoughts, especially later on after the event. Our sleep can obviously be affected. Dreams, nightmares, panic attacks in the middle of the night. Anyone that's got significant post-traumatic stress disorder often recognises these symptoms. The overwhelming things at the time of the trauma are a feeling of helplessness and powerlessness. Let's take a moment just to review the developmental effects of trauma because it's so important. This is when children are living in households where they're unsafe, neglected or abused, they still need to learn and grow despite that environment. They must adapt to an ongoing state of fear, and they're often not soothed or comforted by their parents or caregivers when they're feeling frightened or overwhelmed. Now, we need this parental guidance to learn how to manage our emotions ourselves and how to manage feelings of being overwhelmed. So in order to learn that from a parent, you have to have good attachment, and that's where attachment theory comes in, and you have to have ongoing intimate relationships with your caregivers. Only in that way can you learn to appropriately manage all the feelings that will come our way as we make our way in the world. When you're in a safe and predictable relationship, children feel that they're understood, cared for and valued. So if you don't have that, the opposite occurs. Feeling like this goes hand in hand with the development of a sense of self. We also know that cognitive impairment is a reality for some kids when they suffer from poor attachment. So how does this translate to when we're older and grown up? Well, the ACE study, no one talks about trauma-informed care without mentioning the ACE study. It was a huge study done in the States in the 1990s of over 17,000 people. It stands for the American Adverse Childhood Event Study, and they looked at all of these people, questionnaires about what traumatic events they experienced in childhood, and it was in 8 domains, including all forms of childhood abuse, neglect, witnessing violence in the home, parental divorce, mental illness, substance abuse, incarceration in parents. And what they found was ACE scores of more than 4 were highly predictive of multiple health concerns in adulthood. So this is talking like diabetes, cancer, heart disease, all sorts of physical things. And for those that had a very high ACE score of 7 or 8, all of these things multiplied many, many times. For instance, a 51 times increase in adolescent suicide attempts, and in adulthood, a 30-fold increase in suicide attempts. Unbelievable, really. So, in order to make sense of trauma and how it affects us, it's very helpful to know a little bit of neurobiology. So we're going to do Neurobiology 101. When we get into when we get a fright, then the flight, fight or freeze response is triggered. Okay, this is activated by the amygdala, which is a little walnut-sized part of deep in your brain in the limbic system. It functions similar to a smoke detector, so it's always on the lookout for something coming at you. Saber-toothed tiger, bear in the woods, something like that. All of our senses go into our amygdala at the base of our brain, and these senses are processed, and it allows for a quick, automatic, immediate response to danger. So once the amygdala decides that the threat is real outside, the adrenaline stress response is triggered. So that's adrenaline surge, cortisol from your adrenal glands, and endorphins. Now that adrenaline, we all know what an adrenaline rush feels like, right? Your heart rate goes up, your blood pressure goes up, blood flow increases to your muscles, blood flow decreases to other parts of your body that are non-essential, like your bowel and unfortunately your prefrontal cortex. Now the prefrontal cortex is the thinking, logical part of the brain that says, hey, wait a minute, it's okay, slow down, everything's okay. But when you have that adrenaline surge and that cortisone surge, it's not functioning so well. So we go on autopilot, okay? The reason for that is it makes us strong and quick, and we can run away or we can fight. Now, this is obviously normal functioning and very helpful if you need to get away from an attacker or a fire in your house or something like that. But when the threat is gone, everything needs to settle down and come back to normal. So this is the parasympathetic nervous system. So it has the opposite effect of winding down, lowering blood pressure, coming back to a calm state. Prefrontal cortex comes back into play. A good example of this is cats. So they show this good balance between the sympathetic nervous system and the parasympathetic nervous system. So you have a cat sleeping on your sofa and there's a loud noise. The cat jumps up, hair stands on end, arches its back, looks ready to pounce or to run. And then when it realises nothing's going on, immediately back to sleep. Very good example demonstrating that. However, if the stress is ongoing or recurrent stress, or you're living in a stressful environment all the time, your amygdala is being fired all the time and you're in this chronic stress response all the time, that is not helpful. That is what is damaging long term. That actually changes your brain. Survivors of trauma and abuse often live in environments with constant threat of danger. Basically what we see is all those symptoms that you get when you're initially in the throes of danger, but constant. So hyperarousal, so constantly feeling anxious, jumpy. For people that have ongoing symptoms like this, if you go up behind them and tap them on the shoulder, you know, immediately over response to a physical stimulation. Ongoing sleep disturbance. Hypervigilance, so that's always looking around. Where's the next thing going to come from? And hypervigilance is problematic because it takes our focus from outside our body into environment and away from our internal sense of emotions and feeling who we are and what we're about. And because of that, it is difficult to even start to get a handle on managing emotions and managing impulses. Dissociation is kind of the opposite. So that's again that shutting off in the sense of danger being around. And we've all seen clients, I'm sure, that dissociate intermittently. It's a self-protection. It means that you don't have to feel those overwhelming negative feelings. So we have all these physical adaptations, and then we have to get on in the world. So behavioural adaptations occur, and these are to cope with these overwhelming, continuing emotions and memories. Some of these things are listed here. Self-harm serves for some people to reduce tension and to downgrade that feeling of arousal all the time. For some people that are more dissociative and have that feeling of numbness and disconnection from the world, it can increase their adrenaline and their cortisol so that they can feel a bit more again. Disordered eating, so binge eating, anorexia can be associated with attempts to manage traumatic memories. Alcohol and drug use obviously are ways of self-medicating with depressants and alcohol to reduce those ongoing emotions and stimulants to feel more. Clients who have had strong trauma histories will avoid their triggers. Might just take a moment to say what a trigger is. A trigger is a reminder in the environment or from within that takes you back to the time when you were initially traumatised. And when your mind goes back to that initial incidence of trauma, all of the associated emotions and feelings come back. Okay? So a triggered response, we see someone suddenly goes into a panic when they're reminded for whatever. Sometimes it's obvious what the reminder was, someone being aggressive towards them, but sometimes it can be something as simple as a colour or someone walking by that looks similar to their previous abuser. So people have been traumatised, become focused on their short-term survival and don't really consider the long-term consequences of these behavioural adaptations. And once you have these behavioural adaptations, you've got a much greater risk of morbidity and mortality from all causes. So that means more likely to die at a younger age and have more medical problems throughout life. Keep an eye on the time. Trauma affects identity and agency. As we said, through childhood, particularly childhood trauma, it affects a sense of self. Early abuse distorts the core of a person's identity and results in a lack of trust in relationships. This is because the client is fearful of being triggered and emotionally overwhelmed. So instead they defensively withdraw. As a result, they don't have others to draw on for support going forward. And they often have very big difficulties with boundaries. So some of our clients may be open up and too close to people or too distant. Sometimes we see, and certainly at the Hartwood Centre, we see some clients come in that become fabulous caretakers of other people, you know, excessively concerned about others' well-being. And this is the expense of their own self-care. Spiritual effects of severe trauma include all of those. Loss of meaning and faith. Again, this is back to this sense of self and identity and where one is in the world. Loss of connection with others. Feelings of shame and guilt, very prominent and very damaging. Lots of self-blame and self-hate, especially from childhood. So we can see all these things, and we love to, in medicine particularly, and nursing, we like to label things. So the symptoms and behaviours that we see subsequent to trauma might be missed or misdiagnosed if we don't think about what's happened to that person in their life, if we don't look at it through a trauma lens. So some of these diagnoses might be psychotic illnesses, personality disorders, particularly borderline personality disorder in women, again with that difficulty in relationships and boundaries. Anxiety disorders, obviously, and bipolar. Not to say that these illnesses don't exist, but sometimes they're diagnosed in people with trauma when that may not be an appropriate diagnosis. And we don't want to overdiagnose these medical conditions because it puts us on a treatment path of medication and labelling that might not be helpful for that person going forward. So I'm going to mix it up a bit here now, and you're probably sick of listening to my voice. So we're going to have a case scenario, and I'm going to get you to help me out with some, I'm going to ask you some questions and you're going to help me out with some answers. And have Amanda down the back with a microphone. And she is, if anyone wants to help me out with an answer, just raise your hand. And this is for the studio audience only, I'm afraid. and she can bring the microphone to you. So let's look at our case scenario. Let's imagine that you're working in an outpatient clinic for infectious diseases, and a young homeless woman arrives, and she's got a nasty infection on her lower leg. She has a past history of HIV infection secondary to injection drug use, and she has ongoing polysubstance use. She's presenting with significant pain and is very irritable and agitated. Does this sound familiar to anybody? Perhaps? So first up, if we're going to look through a kind of a more medical lens, she walks in the door. Let's imagine she walks up to the front desk. She's very demanding. She's very verbally aggressive. She's shouting at the girl at the desk, "How long do I have to wait to be seen by somebody here? What kind of service is this anyway? Can't you see I'm in pain?" And stomping around. What would you think of this presentation if you weren't looking through a trauma lens? Any takers? I'll help you out with the first one. So you might think that she's dangerous, that she has antisocial personality disorder, that in short she's a badass, right? Immediately gets your barriers up. If we were to look at this through a trauma-informed lens, what might we think? Why is she behaving like this? Any takers? Amanda, what do you think?
Hi.
Hi.
Maybe she has her defenses up already, even before anything has happened.
Yes,
So
yeah.
she's
likely frightened, right? She's fearful of what's going to happen. She might be really fearful that something bad is going on with her. And that is her response to fear, to be aggressive. Also, she's homeless. She lives on the street. You know, that's not an easy life. She's got to appear tough in order to protect herself. So that's her only way of knowing how to be safe in the world, is to put on this big bravado, right? So next, she's waiting and waiting, and she starts acting very paranoid and thinking, what's going on with this? Why don't they want to treat me? Looking around very suspiciously at everybody, blanking out perhaps a bit. What might we diagnose just from a distance with a medical approach? Paranoid, looking around, suspicious. We might think that she has some underlying psychosis, or that she might have a drug-induced psychosis, that she might be listening to other things going on in the room. But through a trauma-informed lens, again, fear of a new environment, trust issues. So I see patients with bad trauma histories in recovery that really can even develop hallucinations, lots of paranoia and stuff, but don't have any underlying psychotic disorder. It can all be tracked back to the trauma experience. Again, agitated, pacing around. We might think she's intoxicated on crystal meth or cocaine or something, but again, that can just be that state of hyperarousal. She's waiting and nothing's happening, so she starts saying, this is bullshit. I just want my pain meds. Someone needs to give me some pain meds right now, and they need to be decent. I need some morphine. What are we going to think about that when someone starts demanding like that? You got to know this one. Over here.
You might think she's just seeking drugs.
Drug seeking, yeah. How often do we hear that in hospital settings and clinic settings? Oh, here comes so-and-so drug seeking again. If we're looking at it through a trauma, no, you hang on to that. If we're looking at it through a trauma-informed lens, what might it be rather than drug seeking?
She could actually be in pain.
She could actually be in pain. And people that have trauma histories may not cope so well with pain. So what might be painful for us, an infected leg, we might be able to think, yeah, that's really damn painful, but if I can be patient and wait, and I know it will get treated, and in the end it will settle down. For someone that doesn't have their prefrontal cortex engaged, it's just like the pain becomes overwhelming, and all they can think about is relief from the pain. They don't have any of those other coping skills that people without trauma might have to deal with the pain. So she's just expressing her needs in that moment. Let's say you're the nurse now and you're coming along and you need to take a look at that wound, right? You need to see what's going on. So you approach her, get her up on the examining table and go to pull up the bottom of her jeans, or hopefully not pull down her pants, but pull up the leg of the jeans and attempt to undress the wound. What does she do? What the F are you doing? Don't you touch me? How dare you? You know, don't you know I'm in pain? What would we think to that? Obstructive, right? Not willing to engage in care. You know, what does she think she is? I need to do this in order to help her. Looking at it through a trauma-informed lens, what might be going on for her? Someone's going to help me here.
It's a trigger.
Yes. Triggering, just being touched, being approached by somebody, right? Without giving fair warning of what you intend to do, particularly adjusting clothing and stuff, particularly for a woman perhaps, okay? So obvious potential for triggers there. Okay, thank you for your help. So that gives a bit of a flavour of why we need to recognise these behaviours, because then it informs us of how can we help people better in this situation. One way that I found helpful to look at it was to change the fundamental question from what is wrong with this person to what has happened to this person. Does that make sense? That's just something very easy to go back to when you find yourself in a difficult situation instead of reacting yourself. This is not about me, she's not trying to annoy me. What's happened to this woman? So just to summarise, behaviours which are maladaptive in a clinic, they're useful for managing trauma, but they become maladaptive in the future. So it can result in disengagement from services, as we've just discussed, aggression and poor impulse control in new situations, quick deterioration in your personal interactions for power and control struggles. When we try and enforce rules, that may be met with aggression and fear in the person. And minor events, seemingly minor events to us, can actually be significant triggers for the client and precipitate catastrophic reactions. So how do we as clinicians become trauma-informed in our day-to-day work? Engagement. So the minute you meet somebody, the minute somebody comes into your workspace or your clinic, your environment, we want it to be welcoming and friendly. Calming distractions, nice colours, soft furnishings, maybe music in the background, all very helpful for making someone feel more settled. We need to focus on safety as an absolute priority from minute one. We need to attend to the immediate needs. For that person walking in the door, they're very sensitive to how they're feeling in the moment. So if one is cold or hungry or worried about childcare for their children, they're the most pressing needs for that person, maybe not the infection on the leg or their new diagnosis of HIV. So attend to those immediate needs. We need to be very transparent and predictable in what we're going to do. So lots of communication, saying who you are, what your role is, that you're here to help before doing anything to that client, like starting to undress the wound, to always say exactly what you're going to do. And respect healthy boundaries between that person and yourself. Informed consent all along the way is extremely important, because that's giving choice and control back to the client. And that's something that they've been missing in their traumatic lives. Someone else has had power over them. They don't have choices in their life. And so if they lose that choice and control in the clinical setting with you, then that may trigger back to those emotional responses and they're out the door. So our principles of care that should guide us in our practice, in our day-to-day practice, avoid re-traumatisation. So I'm just going to take a minute to talk about disclosure of past trauma. So do we need to know what someone's past history is, what their past trauma is? Sometimes it is very damaging to ask that question, particularly when you don't have any connection with that patient. So you should never ask those questions up front. Unless someone wants to talk about it, then you should be ready and willing and validate that, because by purposely blocking it out fully, that's also not helpful to people. It's like pretending it didn't happen, or it's all in the past and it doesn't matter now. That's not helpful either. So if the client wants to talk to you about past traumas, and often they'll just give little hints of it or give it to you in small pieces as you go through their relationship with them, that's a much safer way to do it. But make sure that he or she is in control of giving that information and that you're not trying to extract it. The only reason you should be asking about it is if you really need to know for the client's benefit, not for your own benefit or because it's on your assessment paperwork. Okay. It usually occurs in a setting of having a strong connection, so you need to establish that rapport and that relationship with that client first. Often, going back in time, speaking to clients, they often purposely don't want to tell you about it because they feel that the story is so horrific that you as a practitioner will be shocked by it, and you won't be able to handle it. So they don't want you to know because they think you might go, oh, this is too much for me, bye-bye, right? And then they've lost that connection with you. Similarly, when we do hear stories of past trauma, we need to be able to respond appropriately. When someone is telling you their story of their past trauma, it most likely is going to trigger some kind of trauma response. And so they're going to demonstrate increased emotions and maybe loss of control over their behaviours at the time. So we have to know how to deal with that. All of us have to know how to deal with that if we're in this business at all, which we all are. So we'll talk about that in one moment. We want to work with the relative strengths of the client and help them to build new appropriate coping skills. We want to set up resiliency rather than try and go back in time and undo the trauma. So we need to cultivate safety in every interaction. We need to be non-judgmental, and we need to avoid confrontational approaches. So disagreeing, challenging, all of that stuff is potentially triggering. We need to pay attention to the spoken and unspoken signs that our clients are presenting to us. And if any of you are familiar, especially the counsellors and social workers in the audience, with motivational interviewing techniques, they fit totally with trauma-informed care. We'll skip over that bit for the minute. Response to upset behaviour. So we reinterpret through the lens of trauma exposure. We notice our own internal reactions and avoid overreacting ourselves. Because if we get excited, raise our voice, look a little bit upset, that's going to be triggering to that client potentially. Provide safety with offering verbal support and grounding techniques. Give them your undivided attention and reassurance. What do you need to be safe right now? And if we do see a full-blown reaction, we need to understand what grounding techniques are and how we can help our client with that. So very briefly, that's reconnecting the client to the present. So they're living, when they go back into this trauma response state, they feel like they're reliving the past, reliving those difficult times. So you have to bring them back to the future. Keep eyes open. Look at me. We're in a safe environment. Everything's okay. I understand. Validate the feelings. I understand how you're feeling, but it will soon pass. Think about the here and now. Think about your breathing. Think about the floor under your feet, and just take time, and it will pass. Very good to practice that sort of stuff when they're not in the moment, so that when they are in the moment, they can engage that, come back to that, and that brings back the connection between the prefrontal cortex and the amygdala, and control is regained. Mindfulness, we'll skip over that, but everybody is probably aware of the benefits of mindfulness. And we'll finish up with practice traps. So what are some of the problems that we run into as practitioners that we need to be particularly aware of? So we need to be careful not to feel like we're fixing and taking over. Oh, it's pretty obvious what the problem is, and I know the solution. You just need to do blah, blah, blah. Well, that's taking away, again, choice and control from the client. So even though you know what the answer is and what would be very helpful for that person, it's not necessarily appropriate to just blurt it out to them. It's quick and easy, but it's not going to get you the results that you want. You have to be careful of feeling overwhelmed yourself. So you have to be really aware of your own triggers and your own sense of being in the world and in the workplace. We must not be rigid in our practice, because then we can't respond to individual needs. If we always just do what we're meant to do, this is how I respond in this situation, you're not going to be responsive to the individual needs of that person. We need to meet him or her where she's at that time. We also need to be very aware of our own body language and expressions. So when you're hearing stories, try not to act too shocked if you are shocked. Try not to employ excessive sympathy, because then that makes the client feel uncomfortable sometimes. Try not to appear frustrated. Careful with your tone of voice. Whenever we get excited, especially me, my voice goes up and speak more quickly. They pick up on all of those cues, very sensitive to those sort of cues. Okay, we can skip over recovery from trauma, or talk about that later on. So I'm going to draw it to a close there, and hopefully I can answer any of your questions that you may have. Thank you.
The title of your presentation was Beyond the Flashback. Can you tell us any more information about flashback and what that is in trauma-informed care?
Okay, so the flashback occurs following a trigger. So the easiest example, and ones that I hear most about, are women that have been perhaps sexually assaulted by somebody in the past, either just a one-off perhaps, and if they're walking down the street and they see someone that reminds them of it, it will trigger a flashback. So the memory is triggered, and then they remember the whole event from before, and they're experiencing it as if it's happening in the here and now. They have no control over that, right? So it's reliving that traumatic experience. I should probably say that many people do have terrible events and are survivors of sexual abuse and sexual trauma. And often, you know, you can have acute stress reaction to that and have flashbacks and sleep disturbance and anxiety and stuff for weeks or months afterwards, but very often we heal from that. So I guess I didn't really stress that you know, these events can have short-term effects, don't necessarily translate into long-term. On the flip side, those flashbacks can go on forever and ever, hopefully reduce in intensity. Yes?
I think you may have started answering the question I had. You know, I really liked your example of well, your poor child who fell from the high chair and dissociated, but how do you differentiate that? Because that to me sounds like a more acute episode, which
exactly,
happens many
and all
times.
of these originate from useful adaptations or useful responses to trauma. That's a very helpful thing, you know, to just dissociate from the pain. You're not feeling the pain anymore. That's great in the moment. It's great when that trauma is happening to you, but you don't want that to happen to you when you're not in danger. Yes. Okay, so that dissociation. So we see, as an example, dissociation. Often we see it in the group setting in our trauma groups in the Hartwood Centre where I work. So when the conversation gets a little more triggering, perhaps people are discussing a little bit what's happened to them in the past, people dissociate immediately. Now, that dissociation means that they can't learn to process those feelings and cope in a more appropriate way by understanding their feelings, recognising they're there, but not having a full-blown reaction.
You know, one of the things, and this is, I guess this is just parenting by natural tendency, not anything learned, but my understanding is, you know, as parents, you try and create an environment that's nurturing and supportive of children, knowing that they'll experience a lot of different things. And then these hiccups and small things that they need to learn. And I don't know, small is very relative. It depends where you stand at that time. But what I'm actually trying to get at is, at what point do some of these experiences reach the point where now we begin to be concerned? Or you can't quantify it in that way. It's very situational. It's very situational.
It depends on the individual. That's getting back to what is traumatic for someone is not traumatic for somebody else. But if we have a strong sense of self from a healthy upbringing, you're much better able to cope. Because of course there's going to be terrible things happening to everybody, throughout a lifetime. The world is not a safe place. Everybody knows that. So if you're happy and safe most of the time, and when little things come along and your parents teach you how to deal with something, like an injury or aggression in somebody else, and deal with it appropriately, then when you're out there and it's much more important to be able to do it on your own, you have those skills to do it. And what kids don't have that grow up in unsafe environments, they never learn those coping skills in the first place. And we are here, and particularly trauma-specific services, to teach those skills, to give control back in these people's lives. Healing is absolutely possible. Just need the right environment.
Thank you.
We've got a text that has come in, and it's a very good question. Dr. Mead, great talk. Thank you very much. How can you help patients understand that I'm not mad, but I'm actually moving quickly because I'm busy?
Just say those words before you do it. So some of this can be done quickly. You might need to put the time in with a patient initially when they're getting to know you, but once you've got their trust, and I do this all the time with patients because I'm often very busy, once I get to know somebody, I say, look, I'd love to talk to you right now, but I got to go, and you run out the door. And they know, oh, that's just her. She always does that. She's not blowing me off. She's not being disrespectful to me. So if you have that core trust, and that's where you need to spend a bit of time with somebody, if you have that core trust, then you're able to be more flexible in your relationship and get on with your work. Because at the end of the day, we've still got to get our work done. It would be nice to sit around and chat all day and drink tea and, what have you, but work has to be done. But put that time in up front, will reap benefits later on in your relationship, and be consistent in that relationship. And if you have to run or you have to do something unexpected, just say, I apologize, and I know this seems bad, but I need to do this, and we'll chat again soon, or whatever.
There's another question that's come in, and it says that you work in women's center predominantly. Are there any differences that you can discuss between the differences between men and women, or even between different cultures, that might help us in the patients that we're going to be looking after?
Okay, so cultural competency is huge, okay? So we need to understand a person's background and cultural environment that they came up in, to understand what's the influences that they've had, the experiences they've had in that context, in order to then understand how they are in the world today, how they are in front of you right now. And so cultural is extremely important. Gender issues extremely important. Of course, I've spoken a lot about women today because that's generally who I deal with. I also do have another job, but it's in the acute care hospital setting. So I see a lot of men through Vancouver General Hospital, often traumatic stuff after accidents, car accidents, or with things like alcoholic-related pancreatitis and things like that. So I deal with a lot of men, but it's much more in the acute care setting, so I don't have the long-term ongoing relationships with male clients so much, so I'm not the best to talk about the differences there. Though my sense is that there's a lot of underlying similarities for both, of course. So that's gender and culture here, very important. And then other things, as any kind of, especially perhaps minority groups, sexual orientation is another very important thing to be aware of. A transgendered population in particular have the highest rates of anybody of histories of abuse. And we're starting to learn a lot more about that. We need to make our environments much more transgender friendly, LBGT friendly, and appropriate. And the only way we can do that is to understand what things might be like for those folks.
Okay, there's another question that kind of follows up and tags onto that. When patients seek care in the emergency room, which are hostile for mental health patients, are there specific recommendations related to environmental controls?
Right. So, like maybe having a separate area for people that are presenting with significant distress or mental health issues would be fantastic in an emergency department. Again, all those things that we talked about in a welcoming environment. So get rid of the cold clinical feel of the hospital rooms and have comfortable chairs to sit in instead of gurneys to lie on. Having appropriately trained staff. I certainly know at Vancouver General Hospital we have a psych triage nurse who is the one that immediately goes to them and is dedicated to spending time with people and attending to the immediate needs. So however you can get that into your emergency department to make it a more welcoming environment, particularly for people with those levels of distress, would be really important. And also reduces the need for medication. I've purposely not talked about medication much today. Obviously, I'm a doctor and I write lots of prescriptions for things. And I see lots of medications being prescribed all the time. And we know that people often feel better with having some Ativan or some Seroquel or something to help manage these emotions. That's fine every now and then if you really need it, but the whole idea long term is to learn to cope with these feelings and emotions and behaviours with coping skills coming from yourself rather than reaching for a pill to fix it. Because that's really just the same, well, I shouldn't say that, similar to self-medicating with drugs and alcohol. Sometimes people need medication, but the long-term goal is to be as least reliant as possible on medications.
Thanks, Dr. Mead. I think you answered the second part of the question about de-escalating the hypervigilant patient and looking at the chaotic environment. You touched upon kind of the environmental emergency room, or even any kind of room that you're going to be looking, dealing with patients.
Sorry, what was that last bit?
When you have a chaotic environment,
yes,
and how to de-escalate, and I think you've touched upon that a little bit.
Yeah. If there's lots of chaos going on in the emergency room, and you know what it's like in an emergency room, everybody's rushing and shouting and going, full bore, and it's distressing for most people, I would guess. Yeah, so just imagine that if you're not feeling well and you don't have coping skills yourself. Yeah.
Thanks. We have two more questions that we've got about 2 minutes to address. From Regina, in order to avoid re-traumatization in situations of abuse when working with female patients as a male clinician, should the client be given the option to speak with a female clinician? I
would say yes. The client should always be given as much choice as possible. It really varies. Certainly in this kind of setting, many clinicians are female, and so it's not a big issue. But I think that if you can have the clients meet the male clinicians and then still have the choice of going with a female, then that choice should be honoured. We have mainly women in our Hartwood Centre for Women, but we have a complementary therapies male clinician who does acupuncture and acupressure and lots of other stuff, and he is wonderful and the women love him. And we have a male doctor who works 2 days a week with us as well, and he's just great. So often there's that initial thing, oh, I'd rather have a woman, but once they meet these guys, no problem, and you would find that, I'm sure, yourself. But we need to respect the individual choice at all times.
Thanks. One last question. Hi, Dr. Mead. What happens with trauma while people are detoxing from IV drug use? Does it become more prevalent or heightened? And this person also says, and thank you very much for sharing your wisdom and expertise.
Oh, that's very nice. Yes, certainly. And that's one of the biggest problems with detoxing people from alcohol and drugs. They come in and suddenly alcohol and drugs has been their coping skills for sometimes many, many years. take that away. Usually they feel lots of physical stuff, so in that setting we use medication to try and ameliorate the physical symptoms and the emotional symptoms, and as time goes by all of the memories and thoughts do come back, and they're finding that they have to learn new coping skills. So that's why it's critically important to have a good detox facility where you can provide lots of emotional support as well as medical support in terms of medications. And so I'll happily use medications for those first week or two. Methadone tapers, Suboxone tapers, medications to help sleep. I think that's all very appropriate in the early stages of recovery from drug and alcohol use. And then as time goes by, gradually reduce the reliance on those things and increase the coping skills. So it's hard work for those of you that work in support recovery and treatment centres, but I'm sure that you'll identify with what I'm talking about there. And at Hartwood Centre, one of the times when people leave earliest is within those first 48 hours, because they're detoxed and the world is suddenly very physically and emotionally painful and they're out. So lots of attention to those first 48 hours. And luckily at Hartwood Centre we find that we have a very low rate of people leaving and a very high rate of people completing their 90 days.
Thank you, Dr. Mead, and we'll look forward to your second half of your presentation this afternoon.